Welcome to Management of Opioid Use Disorder. My name is Kate Marshall. To start with, I have no financial relationships or conflicts of interest to disclose. The opinions and guidance here are my own and don't represent those of any particular organization or entity, and the cases have been modified and fictitious names used. Let's start with what we're going to learn today. First off, we're going to learn how to identify and treat opioid withdrawal. We'll learn how to interpret urine drug testing for opiates and opioids. We'll talk about the 3 FDA-approved medications for the treatment of opioid use disorder, sometimes called OUD, and their mechanisms of action. We'll compare and contrast buprenorphine and methadone for opioid use disorder. We'll talk about 2 common methods for initiating buprenorphine, some discharge resources for a patient with opioid use disorder, and finally, we'll talk about the tricky situation of managing acute pain in a patient with opioid use disorder. But before we get into that, I do want to review some brief but critical concepts in substance use disorders care. As you remember, substance use disorders develop when a brain made vulnerable by heredity, stress, trauma, or a crucial period in development is then repeatedly exposed to a substance that produces significant reward. The brain then encodes the substance as necessary to survival, and behavior changes to reflect that. 10 to 20% of the adult population has an active substance use disorder, and that's not including tobacco. And when we care for people with substance use disorders, it can be helpful to remember that they're chronic, they're relapsing, but they are extremely treatable. We also know that using appropriate language in care and avoiding terms like addict, abuser, dirty, and instead using clinical language like a person with substance use disorder improves the quality of care that we provide and helps our patients heal. Let's start with a case. This is Anna. She's a 31-year-old woman with a past medical history of injected heroin use who presents with a fever and is admitted for bacteremia with suspicion for endocarditis. On admission, her heart rate is 112, temperature 38.2 Celsius, respiratory rate 22, blood pressure 108/72. She reports to you that she injects about 1 gram of heroin over the course of each day, usually concurrently with some amount of methamphetamine. She reports that she first used heroin about 7 years ago at the encouragement of a, quote, bad boyfriend, and she says, "I got away from him, but couldn't get away from dope." When you ask if she's currently working, she shrugs and says, "Nothing you would want to know about." She says her last use of heroin and methamphetamine was about 12 hours ago. She's currently diaphoretic, has dilated pupils, piloerection on her arms and legs, body aches, and her urine drug test is positive for opiates and methamphetamine. So in this case, the first thing I'd like to do is try to identify this syndrome. So take a look at the vitals, the history, the lab result, and the physical exam, and think about what might be going on here. Do you think it's sepsis, opioid intoxication, opioid withdrawal, or stimulant intoxication? Now, in order to answer this question and treat Anna appropriately, we're going to need to compare and contrast these syndromes. To do that, we'll need to be familiar with the symptoms of opioid withdrawal. A good reference for this is the Clinical Opioid Withdrawal Scale, or COWS, which is a scoring system to determine the severity of opioid withdrawal. You can see here that the patient receives points for elevated heart rate, sweating, restlessness, pupil dilation, body aches, rhinorrhea or lacrimation, GI upset, tremor, yawning, anxiety, and piloerection, which are the classic symptoms. A score of 5 to 12 points would be consistent with mild opioid withdrawal, 13 to 24 points with moderate withdrawal, and 25 or more with severe withdrawal. In the outpatient setting, a provider or patient can fill this out, and in the inpatient setting, scoring by nursing is usually orderable in the electronic medical record. As we look at this list, we notice that many of these symptoms are consistent with activation of the sympathetic nervous system. This makes sense because opioids are sedating and tend to activate the parasympathetic system, so withdrawal is the opposite. That also means that opioid withdrawal is easily confused with other sympathetic states, which can lead to inappropriate treatment in some cases. Now let's take a look at the syndrome of stimulant intoxication, another mainly sympathetically mediated state. You don't typically see yawning or rhinorrhea, but otherwise it's very similar to opioid withdrawal. Getting a careful history of the timing of substances will be critically important in telling these apart, and the patient will almost always be able to clarify for you which one they're experiencing. Now, what about sepsis? Again, there's a lot of overlap, and depending on the type of infection you suspect, you may even see GI upset or respiratory symptoms. Again, a careful history will be important here, and many patients have concurrent opioid withdrawal and sepsis when they present to the hospital for suspected infection. In these cases, it's important to let the patient know that infection and withdrawal have a lot in common and reassuring them that you will treat both, any infection and their withdrawal, and will help to allay their anxiety about how their body is feeling. So it seems like Anna might have opioid withdrawal, but is the timing right? Let's briefly talk about different types of opioids that someone might have in their system. This isn't a comprehensive list, of course, but should give you an idea of what to expect and how to interpret the urine drug test for opiates. First of all, we have heroin, also known as diacetylmorphine. It is illegal in the U.S., Schedule I, and may be used as a liquid by mouth, may be snorted, smoked, or injected, and we commonly see folks who inject into the vein, muscle, or skin. The effect of heroin lasts about 4 to 6 hours before redosing is needed to prevent withdrawal. Heroin is a natural opiate from the poppy plant, so on a drug screen looking for opiates will come up positive. And 6-monoacetylmorphine is a unique metabolite of heroin, and its presence is pathognomonic for heroin ingestion. Next, we have morphine, another short-acting natural opiate. This will come up positive for opiates on a screening urine test. Oxycodone is similar in duration to morphine, but is partly synthetic, so it may or may not show up on a screening test that doesn't have a separate oxycodone result. It's important to note that right now there are many fake oxycodone and morphine pills in the community. They may or may not contain what they advertise, but they do typically contain fentanyl. These are known as blues or dirty 30s because they often are blue in color and stamped to look like 30 milligram pharmaceutical pills. When we look at the fentanyl that may be sold as powder or in these fake pills, we see that it has a shorter duration of action and folks are needing to dose very frequently. Fentanyl is fully synthetic and won't be detected unless you specifically test for it. Methadone is an ultra-long-acting, fully synthetic opioid. Again, since it's synthetic, you need to test for it separately. Finally, we have buprenorphine, a synthetic partial agonist opioid with a half-life of about a day. Again, you need to test separately for this. We'll talk about methadone and buprenorphine a lot more in a bit, but let's get back to Anna's withdrawal. She reports using heroin and her urine drug test was positive for opiates, which is consistent with her report. So with Anna's reported use of short-acting opioids, you can expect withdrawal to come on about 4 to 6 hours after the last dose and peak at 2 to 3 days. With long-acting opioids like methadone, symptoms may not come on till 24 to 36 hours after dosing and may peak as late as 7 days. Many patients also experience protracted withdrawal that may require occasional comfort medications for several weeks after discontinuation, and cravings often persist longer than that. Now that we've reviewed the symptoms of opioid intoxication and withdrawal, we know that opioid intoxication is unlikely in this case. However, the other three are still possible. You'll remember Anna said she last injected both heroin and methamphetamine about 12 hours ago. That makes stimulant intoxication unlikely since methamphetamine is relatively short-acting. Her symptoms are most likely due to a combination of sepsis and opioid withdrawal. Now, as you may remember from the session on policy and regulation, there are quite a few options available for treating opioid withdrawal in patients who are admitted to the hospital. Legally, a hospital provider can treat withdrawal with any opioid, including methadone or buprenorphine, without needing any additional waiver or special training. When you speak to Anna about these options, she expresses that she would be willing to take methadone for her withdrawal. However, she does honestly tell you that she's not planning on continuing the methadone after discharge and will likely go back to using heroin. My next question for you is, what should you offer her in this case? Remember, she typically injects about 1 gram of heroin each day, which is a fairly average amount among people who use heroin, but also reflects a decent amount of opioid tolerance. So should you offer her comfort medications, methadone 10 milligrams a day, methadone 30 milligrams a day, or methadone 45 milligrams a day? What do you think? So as we think about this, I'd like to talk a little bit about adjunct medications for treating opioid withdrawal. It can be hard to immediately and completely match the patient's existing opioid requirement with something other than what they usually take. So to treat any withdrawal symptoms they may have while you're getting up to speed on opioids, we have several options for symptomatic treatment. Here are some example dosing regimens from an inpatient order set. Your electronic medical record may have an opioid withdrawal order set offering similar options. In general, these medications can and should be used early and often for admitted patients with concern for opioid withdrawal. Some patients may ask about other medications, including benzodiazepines, Phenergan, or IV antihistamines, as adjuncts to the comfort medications I've listed here. A request for these medications may raise concerns for drug seeking among patients with substance use disorders, and in particular, combining Phenergan with opioids might raise a concern that a patient is seeking euphoria in the hospital. To that end, I'd like to mention that patients are often aware that many common medications are opioid potentiators, meaning they can increase the effect of opioids when used together. These medications or substances are often used intentionally by patients to make their opioids go farther. Patients are quite savvy, so it's especially important for us to be aware of these as well. And what I'd take from this list isn't that you should withhold opioid potentiators from a patient with opioid use disorder who requests them, but rather that you view their request as an indicator that you are underdosing opioids and undertreating their withdrawal. A frank discussion with the patient about whether their withdrawal is adequately treated will be important in these cases. And if it comes down to a patient leaving against medical advice or receiving a benzodiazepine for withdrawal symptoms or anxiety while hospitalized, it's important to consider which course of action carries the greater risk of harm to the patient before deciding to withhold treatment. So comfort medications are an important part of opioid withdrawal management, but comfort medications alone are not a recommended treatment. Let's review the 3 FDA-approved medications for opioid use disorder that are the standard of care and should be offered to any patient with moderate to severe opioid use disorder. First off, we have methadone. As we learned in the policy session, between 1919 and 1974, it was forbidden for providers to use opioids to treat opioid use disorder in the outpatient setting. Methadone was the original exception to that rule. Remember that it's super long-acting, synthetic, full agonist that's usually taken orally. Because of its slow onset and long duration of action, it doesn't usually generate much in the way of reward or euphoria, which makes it ideal to treat opioid use disorder. It staves off withdrawal, and taking methadone daily can make it much easier to abstain from heroin or other opioids. Next, we have buprenorphine, which has been available to treat opioid use disorder since 2002. Unlike methadone, heroin, oxycodone, and most other opioids, it's a partial agonist at the mu-opioid receptor, meaning it binds to the entire receptor and blocks it, but only stimulates the receptor to about 40% the extent of a full agonist opioid. This is the quality that makes it so appealing for treating opioid use disorder, since with partial stimulation, it's much harder to overdose and there is less euphoria. It binds for about 24 hours and has a very high binding affinity, which means while it's bound, almost nothing else can displace it. So this also protects against overdose from other opioids while the person has buprenorphine in their system. It's important to note that buprenorphine has very poor oral bioavailability, so it's typically taken sublingually as a dissolvable pill or strip. Many times, buprenorphine is paired with naloxone, an opioid blocker. One common brand name for this combination is Suboxone. Naloxone, when sold alone or in intranasal administration, is known as the brand name Narcan. But why combine a partial opioid agonist with an opioid blocker? The idea is that because naloxone is not well absorbed sublingually, when the combination is taken as prescribed, the patient should only receive the intended effect of the buprenorphine. However, if the medication is taken not as prescribed, such as intravenously or intranasally, the naloxone will be absorbed and cause opioid withdrawal. Thus, the naloxone is added to discourage medication misuse. It should be noted, however, that in practice, there are some patients who may have adverse effects from the naloxone component in these combination products, even when taken as prescribed. Finally, we have naltrexone, which is an antagonist or blocker at the mu-opioid receptor and doesn't generate any opioid signaling. When used for opioid use disorder, it's only FDA-approved in a long-acting injectable form known by the brand name Vivitrol, which lasts 30 days at a time. It also has a fairly high binding affinity and will block other opioids from binding while it's on the receptor, which is what is most helpful in treating opioid use disorder. Naltrexone does not treat and in fact can worsen opioid withdrawal symptoms if given within a 7-day time window of opioid use. Therefore, we typically wait for 7 days from last opioid use before initiating it. For this reason, patients have significantly greater difficulty getting started on naltrexone compared to buprenorphine or methadone. Additionally, unlike buprenorphine and methadone, naltrexone has not been shown to reduce the risk of death. For these reasons, most opioid use disorder guidelines recommend naltrexone as a second-line option for the treatment of opioid use disorder behind buprenorphine and methadone. Now, the reason that I said that withdrawal management alone is not a recommended treatment for opioid use disorder is this. When we look at rates of return to use among people on buprenorphine, methadone, or who did not take a medication but engaged with intensive behavioral health, the rates of return to use over 3 years are so much lower in the medication groups, 5 to 10% compared to 20 to 50%. And that's why methadone and buprenorphine are so strongly recommended. Let's talk about each of them for a moment. One thing to know about methadone is that the usual effective dose is somewhere in the range of 60 to 120 milligrams daily, but because of the long half-life and potential for stacking during up-titration, the maximum recommended dose on day 1 of treatment is 30 milligrams, with the option for an additional 10 milligrams later that day if needed. In the outpatient setting, that maximum dose is codified into law, so you can't increase too quickly, and in the outpatient setting, a patient may continue to use other opioids for several weeks until you get to the effective dose. So in the hospital, you might need to use other opioids to stave off withdrawal while you up-titrate as well. And once they discharge, they will need to go to a methadone clinic for treatment, which is typically a daily obligation and comes with required counseling and group sessions. One advantage to daily dosing is that the patient doesn't need to take medication home, so if the patient is concerned about losing medication or that it will be stolen, that can be a good option. For buprenorphine, the usual dose is somewhere in the range of 16 to 24 milligrams daily, and you can get there on day 1 if needed, usually more like day 3 for a traditional initiation plan. Unlike methadone, patients can get buprenorphine from their primary care provider or by telehealth, and usually start out with a week or more supply at a time. But which to choose? Many studies show that they are comparably effective for the most part, and when we compare and contrast them, we see that both have a very low number needed to treat to keep folks in treatment. When it comes down to it, many patients have an opinion on which medication will work best for them, and that's the medication you should probably start. The rest is details. So in Anna's case, I would offer comfort medications right away and probably start methadone at somewhere around 20 to 30 milligrams a day. 10 milligrams is likely too low given the extent of her withdrawal and her pattern of use, and 45 milligrams is above the recommended maximum of 40 milligrams on day 1. And you want to grab a screening EKG and order some as-needed rescue naloxone when starting methadone in the hospital. So during her stay in the hospital, Anna's blood cultures come back positive for MRSA, and an echo shows that she does indeed have endocarditis. After starting methadone at 30 milligrams, she is feeling much, much better. Now, many physicians would plan to keep her at about 30 to 40 milligrams of methadone daily in the hospital if she isn't planning to continue it long term. That amount should be enough to stave off most withdrawal, but is unlikely to completely relieve cravings, as long as both you and she are aware of that. However, Anna is now feeling so much better that she asks if she can change her mind and stay on methadone long term. And that's great because it gives you some freedom to increase the dose toward that usual effective dose of 60 to 120 milligrams a day, and you can arrange for a smooth transition to an opioid treatment program at whatever dose you safely reach. When you speak to Anna about methadone, she asks if you are also planning to test her for HIV and hepatitis. She says she tested positive for hepatitis C a few years ago, but never followed up. She reveals that after losing her housing due to a positive urine drug screen, she's been staying with the person who supplies her heroin and methamphetamine, and says, "They don't let me stay for free, you know." She's worried she may have HIV as well now. You check the infectious disease panel you ordered on Admit and let her know that fortunately she was HIV negative and negative for syphilis, gonorrhea, and chlamydia, but her hepatitis C antibody is positive and the viral load is pending, so you're not sure yet if her hepatitis is active. She asks if she would be eligible for treatment. So my next question for you is, which population is not eligible for treatment of hepatitis C? Would the treatment be contraindicated in patients with active substance use? What about patients with no evidence of liver fibrosis? Or patients with ongoing high-risk sexual behavior? What about patients with concurrent HIV and hepatitis? So it turns out that all these populations are eligible to be treated for hepatitis C. According to the most recent IDSA guidelines, early treatment is key to preventing the spread of hepatitis C in the community, especially for those at highest risk of transmission. And in the case of concurrent HIV, the risk of progression to advanced liver disease is actually higher and places more urgency on getting that treated. If Anna's test shows active hepatitis C, she should be referred for treatment, even if she has ongoing substance use, no liver fibrosis, or ongoing high-risk sexual contact. It's also important to note that pervasive inequalities in who is offered treatment for hepatitis C are common, with Black patients, for example, less likely to be prescribed treatment than white patients. And many state health plans have only recently allowed eligibility for vulnerable patients, such as those who use drugs. After a couple of days, she's up to 40 milligrams of methadone daily, plus her antibiotics, ondansetron, and hydroxyzine. And fortunately, her hepatitis C viral load is 0, indicating she cleared her infection at some point. But then, a repeat EKG shows prolonged QT interval of 510, up from her baseline of 470. She's asymptomatic, and electrolytes are within the normal range. Other than monitoring her on telemetry, what should you do at this point? Should you discontinue the ondansetron and the hydroxyzine immediately? Should you reduce the methadone dose now? Should you continue the medications as is and recheck an EKG after the endocarditis is resolved? Or should you switch to buprenorphine now? So this question is really getting at the risk for dose-dependent QT prolongation with methadone, and how you can mitigate the chance of torsade de pointe and possible sudden cardiac death with a QTC now above 500. Let's talk about that for a minute. As I mentioned, the usual effective dose of methadone is in the range of 60 milligrams to 120 milligrams a day. That's the point where you can expect people to typically stop using other opioids at the same time as methadone in the outpatient setting. However, many opioid treatment programs will limit the maximum dose of methadone in someone with risk factors for harm, like ongoing concurrent alcohol or benzodiazepine use, or prolonged QT. So in this case, with the QT already above 500 at 40 milligrams of methadone a day, I am very concerned that she won't be able to get to an effective dose of methadone without high cardiac risk. Even with discontinuing the other QT prolonging meds, it's unlikely she'll be able to get to those effective doses. So at this point, you do need to stop the other QT prolonging meds, And you need to see if she's willing to switch to buprenorphine, which is more likely to be an effective treatment for her than dose-limited methadone. If she is absolutely unwilling to switch, you would need a frank risk-benefit discussion with her about the high risk of sudden cardiac death on methadone, and that she will face probable future limitations on methadone dosing. And with the QT over 500, you might even need to reduce her dose now. Continuing as is isn't a good option. So how do you start buprenorphine in somebody already on methadone? Now, the biggest trick about starting buprenorphine has to do with that 40% stimulation at the opioid receptor and extremely high binding affinity. Imagine someone has an opioid in their system that's bound to the receptor and giving 100% signaling there. Then buprenorphine comes along and rips that opioid off and binds there itself, signaling at only 40%. When that happens, it causes immediate and severe withdrawal symptoms, like slamming on the brakes to go from 100 miles an hour to 40 miles an hour in a car. That's what is known as precipitated withdrawal. People new to prescribing buprenorphine often worry that they're causing precipitated withdrawal. How can you recognize it? Well, I'll let you know that it is not subtle. It's actually defined as a sudden increase in COWS score of 10 to 30 points within 5 to 20 minutes of taking buprenorphine. As you can imagine, it is incredibly unpleasant and even traumatic for patients. One thing that's important to mention is that it is the buprenorphine itself that causes precipitated withdrawal, not the naloxone component of buprenorphine-naloxone combination product. Buprenorphine is what causes the effect. So the principle behind any kind of buprenorphine initiation is that you need to be aware of if and how you displace other opioids that might be in the system. Let's look at two types of buprenorphine initiation: traditional versus low dose. A traditional initiation relies on waiting until enough of the other opioid has washed out of the system that adding buprenorphine will create a net increase in opioid stimulation, even at 40% per receptor. A rule of thumb is that once the COWS score reaches 12, or it's been about 12 to 24 hours since the last short-acting opioid, you're in the clear to start buprenorphine. However, in the era of widespread contamination of heroin with illicit fentanyl, that rule doesn't always hold true anymore. Fentanyl may be in the system much longer due to its high lipid solubility. Essentially, when used chronically, fentanyl is stored in the body fat and slowly released over days and days, even after the last dose. Buprenorphine could then cause precipitated withdrawal even after multiple days since the last use. That's why many clinicians are moving to option number 2, a low-dose initiation plan, also sometimes called a microdose initiation. In this plan, the full agonist, such as heroin, fentanyl, or methadone, is continued, while tiny amounts of buprenorphine are added into the system on a regular schedule. With each dose, the buprenorphine binds up more and more receptors without kicking a lot of the other opioid off all at once. Once you're at about 12 milligrams buprenorphine per day, you should be able to simply stop the other opioid, and the patient shouldn't notice any withdrawal, because the buprenorphine has slowly and sneakily bound up most of the opioid receptors. So in Anna's case, we did stop the other QT prolonging medications and transitioned her from 40 milligrams of methadone to buprenorphine over the course of 6 days using a low-dose initiation. She was comfortable on 24 milligrams of buprenorphine daily for the remainder of her admission and completed her course of IV antibiotics. My next question is around discharge planning. I've mentioned that the laws are complex around medications for opioid use disorder, so it's worth a review. So which of the following are true? Inpatient providers can give up to 2 weeks of buprenorphine on discharge, even without an X waiver. Inpatient providers can give up to 72 hours of methadone on discharge. 8 hours of education are no longer required to obtain an X waiver for buprenorphine. Or, because buprenorphine is a controlled substance, it cannot be prescribed via telehealth. Which do you think is true? So in this case, only C is true. A is false because while inpatient providers don't need a waiver to provide buprenorphine during an admission, that X number will be required to fill a prescription at the pharmacy for discharge. B is false because, similarly, methadone for opioid use disorder can't be dispensed from a pharmacy. The patient must follow up at a specialized opioid treatment program for methadone, and so arranging a next-day intake is critical for discharge planning for methadone. C is true because, as of April 2021, the educational requirement was waived for providers to obtain an X number and start treating up to 30 concurrent patients with buprenorphine. All that's currently required is a notice of intent submitted to SAMHSA. D is false because buprenorphine can be prescribed via telehealth. Until the COVID-19 pandemic, an in-person assessment was required to establish care, but during COVID-19, a virtual visit works too. These telehealth flexibilities may change when the COVID-19 public health emergency ends, so just be aware of that. So as you consider Anna's discharge, you have several options for follow-up. Many primary care providers are able to prescribe buprenorphine. She also has the option to access addiction-specific outpatient care through a recovery clinic or center. Lots of buprenorphine-specific telehealth services are currently available and accepting new patients. In your area, you may also have a bridge clinic associated with the hospital that can temporarily prescribe to patients on discharge and find them longer-term follow-up within a few months. As it happens, Anna follows up in your primary care clinic. She's feeling well on buprenorphine naloxone 24 milligrams daily and reports no return to heroin use, no cravings, and no bothersome side effects. However, when she followed up with cardiology, she learned that she will still need tricuspid valve repair now that antibiotics are complete. She's very concerned about pain control around the operation, and she wants to know what to do about her buprenorphine when she goes for surgery. So what should you do? Should you discontinue her buprenorphine in order for her to be able to get pain control with full agonists around the time of the operation? Would you dose reduce the buprenorphine so she can get that pain control? Would you continue the buprenorphine but just divide it into 3 times a day at the same dose? Or would you reassure her that her history of high exposure to opioids will lessen her pain around the procedure? So let's talk about the approach to pain in a patient with opioid use disorder, starting with the basics without considering her buprenorphine for now. When patients with opioid use disorder have pain, providers often fear feeding their use disorder and so try to minimize opioids at all costs. They tend to either give the same amount or fewer opioids compared to patients without opioid use disorder with the same type of pain. However, it turns out that rather than protecting against acute pain, long-term exposure to opioids actually increases sensitivity to it. We see in studies using controlled stimulus that patients with opioid dependence and tolerance feel pain at lower amounts of stimulation and have higher intensity of pain than controls. And they in fact typically need more opioids to get control of acute pain than other patients. Sadly, this is often interpreted as drug seeking, when really they do require more opioids to attain the same amount or adequate pain relief. Another consideration is that patients with opioid dependence need a certain amount of opioid in their system in order to feel okay or neutral. This amount is their opioid debt. If you're not meeting the debt, they have withdrawal, including sympathetic overdrive. For this reason, you must pay the opioid debt before you are able to treat acute pain. That's the reason it's usual practice to continue buprenorphine or methadone perioperatively. In the past, it's been more common to stop buprenorphine therapy out of concern for not being able to get full agonists to bind to those opioid receptors while buprenorphine is there. But stopping the buprenorphine causes withdrawal, which you then need to manage and creates a risky period where the patient isn't on medication for their opioid use disorder. Instead, we typically recommend reducing the buprenorphine dose if the total daily amount is more than 12 milligrams. At 12 milligrams daily or less, you should have room for full agonist pain medications to bind. though it's also been shown in case series that patients can attain pain relief on their usual dose of buprenorphine. Buprenorphine and methadone also have some effect for pain, especially when dosed multiple times a day. So divide up their dose into 3 times a day or 4 times a day to maximize the analgesic effect of the medication they're already on, using it as a sort of base layer to add other medications on top of. And remember, you can't expect someone's usual dose of opioids to treat new and acute pain. So have high-potency, full agonist opioids at higher than usual doses ready for severe acute pain. This patient already has opioid use disorder. That horse is out of the barn, and you are not going to somehow make their disorder worse if you treat their pain. Undertreating, on the other hand, creates risk for in-hospital use of outside substances, unplanned discharge, and acute withdrawal, all of which are high-risk situations for the patient and are likely to harm them. So for Anna, I would recommend against stopping buprenorphine. If you do, you'll need to deal with both acute withdrawal and acute pain. You could dose reduce or keep her dose the same and use full agonists on top of her usual dose for her acute pain. And her history of exposure to opioids makes her more vulnerable to severe and early acute pain, not relief from it. Which brings us to the end of our talk on the management of opioid use disorder today. Today we learned that opioid withdrawal manifests as sympathetic overdrive, and the symptoms may overlap with stimulant intoxication or sepsis. We talked about the 3 FDA-approved medications for the treatment of opioid use disorder: methadone, buprenorphine, and intramuscular naltrexone. Buprenorphine and methadone are considered first-line options because they are about equally effective for treating opioid use disorder and reducing the risk of death. Patient preference should guide you if neither is contraindicated. Buprenorphine can be initiated in moderate withdrawal or using a slower, low-dose initiation. And finally, patients with acute pain often require higher than usual doses of full agonist opioids on top of their usual opioid dose to achieve pain relief in the setting of existing opioid use disorder. Thank you.